Welcome to today's Kenya Society of Anesthesiologists hosted weekly webinar. We thank you, our audience, for joining us. It's always a tremendous privilege to have you with us. And we see you tuning in from various allied specialties and cadres and from across the globe. And I say it every week, I'll say it again today. It is because of and for all of you that we congregate. Thank you. So I want to thank our invited speaker, Dr. Kynes, for taking the time to prepare and deliver today's presentation, for our panelists who I'll introduce in detail later in the program, for contributing to this exchange of knowledge, the executive committee of the KSA for organizing this series, our sponsor today, AbbVie, for partnering with us, not just today, but on various other ventures, the Kenya Society of Anesthesiologists and all her members and affiliates, Ms. Shell Macharia, our society administrator, who always ensures smooth running of this forum. Thank you. My name is Angela Ongewe, and I'll be your moderator for this session. As everyone present today has already registered, we won't require you to send your details in on the chat, and that will leave that space open for questions and comments, which we will direct to the speaker and the panelists during the Q&A at the end. So with that, we welcome Dr. Matthew Kynes. He's a pediatric anesthesiologist and assistant professor of anesthesiology at the Vanderbilt University School of Medicine in the US. Among many, many successes, he was a creator of the global anesthesia track at the Global Leadership in Anesthesia Pathway, to include research support, mentorship, and educational curriculum for residents, focused on developing global health skills throughout residency. And indeed, for 3 years now, he's been the Kijabe International Anesthesia Rotation Coordinator, so he's dear to our hearts. This citizen of the world joins us today to share his insights on the practical considerations in the anesthetic management of patients during the COVID-19 pandemic. Welcome, Dr. Kynes.
And thank you very much. And I do want to say asante sana to Dr. Gawe and the KSA for inviting me to be here. I'm very honored to be a part of this discussion and to join you all. Also excited to learn more about how people are dealing with this pandemic across the globe. Also want to thank you as well to AbbVie and the other sponsors. Let me go ahead and get started, as long as you can see my screen well. I don't have any disclosures to present to start, and I just want to give you an outline of what I'll be reviewing today. Obviously, there's a lot of information out there that we could cover, but I've tried to hone in on things that I think are most relevant to us working in the perioperative space. So we'll start with a brief background on the pandemic and the effects of this virus in patients, and then shift toward talking about risks both to patients undergoing surgery that are affected by the disease, as well as risks to us as providers that are caring for these patients. I'll talk about strategies for protecting providers and facilities from the spread of the disease, and also shifting toward planning for how to manage elective surgeries and other types of operations safely during this pandemic. Finally, I'll close with some special opportunities that have come up as a result of this, and then give plenty of time for discussion at the end with our other panelists, as well as addressing questions from the audience. I do want to just give a quick introduction. I'm speaking to you today from Nashville, Tennessee, which is in the southeast of the United States. I do work at Vanderbilt, which has a children's hospital where I spend much of my time. If you need to know one thing about Nashville, it's that it's known as Music City, and there's a lot of production of music spread around the world, and a lot of live music, although that has been shut down temporarily. I also want to mention that my practice has been hugely influenced by the friendships and connections that I've made at Kijabe Hospital, where I've visited since 2014, and most recently spent 6 months working there alongside with my family last year. During that time last year, I was honored to get to know the anesthesiology community of Kenya and East Africa much better, and had plans to be back there again fairly recently. But of course, things have changed a lot since that time. And those plans, as well as the plans of many others across the world, have changed. The emergence of the coronavirus, the virus that causes COVID-19, has obviously impacted the entire globe. And there are health systems and societies that have been thrown into lockdown and uncertainty in ways that we haven't faced before. As we go through this talk, I want to address these objectives and hope that together we can understand the impact of COVID-19 on surgical care systems, including anesthesia care, better, that we can be equipped to enact evidence-based protective measures for ourselves and our staffs to prevent the spread of COVID-19 in our environments, and then finally to foster collaboration to be able to confidently develop plans to proceed with surgery safely during the pandemic. As we all know and experience on a daily basis, anesthesia is a team sport. And I hope that we can reflect on the assistance we can give to one another to make headway during this unique and challenging time. So let's move on to the background. As you all know, this virus has spread across the globe since its emergence in January. And at this point, worldwide, they're approaching 20 million cases and over 725,000 deaths. At a country level, some countries have fared worse than others, and unfortunately, my own country is at the top of the pack. We passed an unfortunate milestone this past week, surpassing 5 million cases documented since January. Just yesterday, we recorded 1,500 deaths and have totaled over 160,000 deaths this year, averaging over 1,000 daily for the past several weeks. So we are by no means in control of this and very much in the midst of managing this. In many African countries, and Kenya included, they do not have now the nearly the same documented volume of cases or deaths that we've seen in Asia, Europe, and America to this point. Kenya, with 25,000 cases thus far and just over 400 deaths, still on the surface doesn't appear to be affected in a widespread and significant way relative to other countries. Looking at the continent as a whole, the Africa CDC has registered over 1,000 cases with 23,000 deaths. This represents 5% of all cases and deaths reported globally. The proportion of this actually has been largely concentrated in South Africa to this point, which has reported 65% of these cases, with the rest spread across the continent. East Africa, where many of you are, has reported 11% of this total. This map shows the daily new cases averaged over a 7-day period. And you can see that places like the US, Brazil, India, Western Europe are still dealing with large numbers of cases each day. And Africa apparently has not had that same level of impact, at least currently. This doesn't tell the whole story, unfortunately. One issue that I'm sure you're aware of is that testing is a challenge in many parts of the continent. Average numbers of tests per 100,000 people on the continent still remains less than 5% of what it is in Europe and Asia to this point. This sample of countries on the left shows the large disparity in testing numbers in these settings. The map on the right also illustrates the limited reporting and data on testing prevalence that we have coming from many parts of the continent at this point. And this does present challenges in understanding exactly where along the course of the pandemic the countries that you all are in right now lie. In addition, this map shows the biweekly change in COVID-19 cases at a country level. Darker red countries represent larger increases in case numbers. And you can see that while the continent is a mixed bag at this point, some countries going down, some countries going up, there are several areas that cases are increasing fairly rapidly. And hopefully something that will be contained soon, but may indicate an emergence of surging of the disease. Kenya's trajectory for daily new cases, as you can see in this chart, has climbed steadily since May, could be leveling off somewhat in the past few weeks. But all this together just says to us that in Africa, as well as in many parts of the world, the situation related to COVID-19 still remains precarious, and we're still very much in the midst of managing this. There are several reasons why this virus has been especially problematic. We've certainly been exposed to many respiratory viruses and other illnesses at an international scale, but this one has presented unique challenges given its specific pathology. Some of the characteristics just summarized in this chart as compared to other respiratory illnesses that have the potential to reach pandemic levels are its transmissibility, or the R0, the number of cases that are spread from each infected person. Although that varies from place to place, depending on local dynamics, it overall appears that COVID-19 is very transmissible, more so than other viruses that we've encountered. In addition, the interval between the symptom onset and maximum infectivity of this virus is very short, meaning that patients can pass the virus along very rapidly before or just as they are showing symptoms, making it more difficult to contain. Fortunately, many patients do have mild illness. However, this means that the likelihood of the virus to spread rapidly without being detected is high. And all of this has resulted, as we've already seen, in a pandemic that has reached very significant proportions, even relative to even surpassing seasonal influenza in the worst seasons. It's something that we haven't dealt with at this level in quite a long time. The disease process, I won't spend much time talking about it, but just by way of background, begins with a viral response that is largely asymptomatic in the early phases. Some symptoms may be a mild fever, a dry cough, loss of smell or sense of taste, but usually these are well tolerated. For a subset of patients, they do progress to a pulmonary phase, which would be manifested with shortness of breath, occasionally with hypoxia that may be severe. And many of these patients require admission to the hospital. Subset of these patients do progress into a hyperinflammatory phase, which really is the cause of the most severe complications and death in patients experiencing this disease. They can present with ARDS, shock, cardiac failure, high need for intensive care and critical care support, and high likelihood of death reaching this point. These images show the severity of lung damage that can occur in COVID-19 patients, both by X-ray and CT scan. And really, this is something that obviously causes major issues for patients that progress to this point, and a very large challenge clinically to rescue them when they've reached this severity of disease. I'll touch briefly on testing, which is an evolving area as relates to COVID-19. Several testing modalities are now available, and they can detect the disease at an asymptomatic or early stage, as well as later at the more symptomatic phases of the illness. These are very important, obviously, to guide detection of the disease, to initiate treatment, but also importantly, to give a sense for how widespread the disease is and to isolate or quarantine patients who may be affected and reduce their likelihood of spreading it to others. The current tests are molecular, antigen tests, or antibody tests, each of them with different features, making them useful for different parts of the management of this condition. The molecular tests use viral RNA to diagnose the infection, most likely to be positive within 1 to 7 days after symptoms, although it can be used in asymptomatic patients, and the results do take a little longer, from 1 to 7 days, to return. The antigen tests are the more recent point of care testing that can be available within an hour, although the false negative rate is slightly higher for these tests. And then finally, antibody tests are able to show the presence of a prior infection and aren't as useful in the perioperative area that most of us are working in, but do get used for looking at the prevalence of disease across the population. With that background, we'll move on to talking about risks specifically in the perioperative space. What are the risks for patients who have COVID disease who require surgery? What are the risks to the healthcare workers who are treating them? And finally, what are the health risks across the entire health system if surgeries are delayed or impacted by the presence of this disease? I want to ask Shelmuth to present this poll question. I think it'll be interesting to see some of the responses that are out there. We'll have a couple of questions interspersed throughout just for some interaction. You can see the poll is up there. I'll give you about 30 or 45 seconds to answer. I'll read the question aloud. What is the general level of preparation among staff at your facility for managing known or suspected COVID-19 patients? No preparation or training, minimal training with large gaps, some training but gaps remain, or fully trained and prepared to deal with this. You can see the responses coming in. It looks like many are in that middle range with either minimal training or some training, but some room to grow, which probably across the globe would be true. Good, thank you for participating in that. I'll end the poll and can see what the results are. You see that the highest number, 58%, have had some training, but there are gaps that remain. And I think that is probably where many of us find ourselves, partly because of the challenge of the emerging nature of this disease. We'll go on to another poll. Shifting from the level of preparation to the level of comfort, which for some people may be the same. I'll have Shelmuth share this poll. And I'll read it aloud. What is the general level of comfort among staff at your facility for managing known or suspected COVID-19 patients? Extremely uncomfortable or unwilling, uncomfortable but willing, comfortable but with uncertainties, or ready and eager to help? Good, thank you for your responses. So we can see that for this level of comfort, the majority kind of in an uncomfortable but willing category. Again, that's not surprising. This is a challenging situation to be in, and there are risks to healthcare providers. At the same time, we can see that our job and our duty to our patients supersedes those, and many people are still willing to do that. Well, hopefully over the next few slides, I'll give you some tools to improve the comfort and preparation that you have that you can share with your staffs. This next few slides will talk about the risks to patients undergoing surgery with a COVID-19 diagnosis. COVID Surge is the largest study of surgical outcomes for patients diagnosed pre or post-operatively with COVID. This study looked at 30-day results in a cohort of patients and included 1,100 adults who were undergoing a broad range of surgeries. Coronavirus infection was diagnosed post-operatively in 3/4 of these patients, which does reflect the challenges of identifying all of these patients as they come in. About 25% of these patients were actually elective surgeries, which is important to note. Looking at their 30-day outcomes, the primary outcome of mortality was high at 24%. 50% of patients did have post-op pulmonary complications, and these led to death in a significant proportion of these patients. Although there's not a control group to compare for this study, this does suggest that operating on patients with the disease can lead to poor outcomes. This is another recent study looking to assess the impact of COVID diagnosis on surgical outcomes by comparing groups with and without the disease. In this group of patients, those who did not have COVID had poorer outcomes based on patient age, CRP, ASA class, which is not surprising. When they compared to a matched group of patients with COVID-19, that diagnosis had a stronger relationship with poor outcomes than any other factor. And in fact, the mortality of the two groups that were well matched was tenfold higher, nearly 20% in those with COVID-19 compared to those who did not have COVID-19. So there are risks to doing surgery on patients who have COVID-19, and one option is to reduce the number of surgeries temporarily to protect patients as well as to protect providers, which we'll go into a little bit later. However, surgical delay has its own consequences as well. And nowhere is this more important than Sub-Saharan Africa. This is the time, and there's a lot of effort from many organizations, including KSA, to expand surgical capacity and volume, and that's an important work to do. And now is not the time to reduce those efforts. This chart actually shows the surgical need in the bars on the left side, with the mean global need in the middle. You can see that to the right, the greatest surgical need worldwide is in countries represented in this region here, the Eastern, Central, and Western Sub-Saharan Africa regions. At the same time, the green bars represent met surgical need in these settings. And unfortunately, there remains a large disparity between met need and estimated total surgical need in these settings. These settings where many of you are working do have gaps that remain and are need to be addressed, and as much as possible should not be interrupted at any cost. As I mentioned, cutting back surgical volume to protect providers. This is especially relevant to those of us who work at the head of the bed. COVID is transmitted through droplets in contact, and during aerosol generating procedures is much more likely to be breathed in and spread infection. As you all know, we're involved in these procedures every day, from mask ventilation, intubation, extubation, doing LMA placements, doing bronchoscopies. There are other procedures that have been suspected as having the potential to spread this infection as well. The virus is spread through droplets primarily, but also through aerosols, and there have been studies to look at how this might affect providers, even those who have full PPE available. And this one study looked at tracing droplets around the time of common procedures like IV placement, intubation for simulated patients who have the disease, and found that several areas that were not protected, including the head and neck, did have evidence of droplet distribution, showing that even with adequate PPE, there are precautions that need to be put in place to minimize the risk of spreading this infection to our healthcare providers. And there has been evidence that this has been occurring. Early reports from Italy showed about 10% of all COVID cases were among healthcare providers. That led some people to kind of isolate themselves even from their own families to prevent bringing this infection home. This has been an ongoing issue and concern in the US. Early on, rates of infection among healthcare providers treating patients remain in the 3 to 5% range. Most recent data from 5 million total cases in the US show about 130,000 or 2.5% of those cases were among healthcare providers, although that's probably an underestimate. Among those cases, as many as 11,000 may have required required a hospitalization, and 600 deaths have been reported in the U.S. among healthcare providers. Likely the number is even higher than that. So there are risks present in managing these patients. There was an interesting study recently looking at quantifying what that risk might be for hands-on providers in anesthesia. These authors, over a period of 3 months, collected data from 500 hospitals in 17 countries and looked at 1,700 healthcare workers who did intubations of patients with COVID-19. They used a combined endpoint of COVID-19 diagnosis, self-isolation, or hospital admission among these providers, and found that during that 3-month period, 10% of those providers went on to have one of those endpoints. This chart shows the days after their first intubation and the number of, or the percent of providers that had one of those composite endpoints. The authors mentioned that there are certainly other places that healthcare workers could be exposed to the virus, including in the community itself. But this is, I think, an interesting attempt to quantify what that risk might be. They also mentioned that of the cases that they looked at, 12% did not have minimum WHO PPE standards. They didn't associate that directly with the likelihood of ending up with a COVID or a suspected COVID case. But that is important to note that adherence to PPE standards is critically important. And I'll shift to talking now about what that adherence could look like and how we can think about implementing that in our environments. I have another poll question here. Shelma could present this. This relates specifically to PPE, which has been a global challenge. And I'm sure in my facility as well as others, it's been an ongoing issue. Here's the question: what is the status of your facility's supply of PPE, meaning N95 masks, gowns, face shields, for a surge of COVID-19 patients? And this ranges from not currently adequate and unlikely to be supplied, to not currently adequate but available on request, to adequate for the short term but likely to be exhausted in the intermediate term, or adequate for the short term and beyond 3 weeks. And I can see a lot of responses coming in here. Good, we'll go ahead and stop the poll there. And unfortunately, as you can all see, we still have a large number of people reporting that their supplies of PPE are not currently adequate. It's good news that they may be available on request, but obviously there's a lot of work to do to address these problems. This of course, is what we think of when we say PPE, gown, face shield, surgical mask, or certainly with aerosol generating procedures, an N95 respirator mask, and gloves for management of any patient suspected or known to have COVID-19. One of the key parts of this is the N95 mask. The N95 mask uses nanofibers to trap particles through a process of electrostatic absorption, and is important in preventing viruses from entering into the respiratory system. It requires a correct fit to function well, but when it is functioning well, it can work significantly to reduce the risk to providers in these situations. Unfortunately, this, and as reflected in the poll that we've just gone, has been hard to come by in many parts of the world. I saw this correspondence about a health administrator at a hospital in Massachusetts here in the United States, who described the back alley deals and negotiations that it took for him to get adequate PPE for his employees. And this quote was telling: "Did I foresee as a healthcare system leader working in a rich, highly developed country that my organization would ever be faced with such a set of circumstances? Of course not." And this is a story that's been repeated across the United States and across the globe, the challenge of getting adequate PPE to protect our healthcare providers from getting this disease. Obviously, supply chains and the huge increase in demand have made this difficult, and because of this, there's been an effort to figure out how to extend the use and reuse things like N95 masks and other personal protective equipment. There's a useful site called N95Decon that has presented some information about how best to do this for N95 masks. They've looked at several different methods that I'll present here. One is using heat and humidity. So that combination is very effective at reducing the presence of virus on these masks while maintaining their function. Another one, which is an expensive solution but is available in some parts of the world, is using UV radiation to neutralize the virus on these masks. And then finally, this is very over time. This does take several days, up to a week, but with the rotation of masks or storing these appropriately and giving them adequate time for that virus to degrade can be a way to extend their use over time. Things that they recommend not doing are using soapy water, alcohol, storing for just one night, which is not enough time to neutralize the virus on the mask, or using bleach immersion, all of which could damage the function of the mask. They have looked at how these masks function using these different methods of sterilization and shown that they still function very well at preventing entry of virus particles through the mask. Based on these recommendations, the Anesthesia Patient Safety Foundation has provided some guidelines about how to decontaminate these respirators and other masks. And they recommend, for any of these masks that have been used and are still unsoiled in good working condition, using either heating, UV light, or steam with heat for at least 30 minutes or up to 60 minutes, and reusing that cycle for at least 10 times will maintain the function of the mask and remains highly efficient to be able to reuse them on a daily basis. So something that you could consider in your environment if PPE supplies remain low. So move on to talk about beyond protection of staff at a hands-on level to higher level planning for continuing surgery safely through this pandemic, and talk about some recommendations we can consider for that. This will be our last poll question. I'll have Shelmuth present this. And the question is, how is your facility currently handling elective surgeries? And I do put elective in quotes. It has a varying definition. These are surgeries that could be postponed 3 to 6 months without major side effects for the patient. So options: only emergency surgeries or no surgeries are allowed in your facility. Some elective surgeries are allowed, but the target is below capacity. All surgeries are allowed, but the volume remains lower than pre-pandemic levels. Or all surgeries are allowed and the current volume is at or above pre-pandemic levels. See a lot of responses coming in for this. Good, and we can stop the survey right there. And you should be able to see that although there's a range of responses, many people fall in those middle categories where some elective surgeries have been resumed or have continued to resume, but volumes remain low. And we'll talk about some of the implications about that and how we can think through that. There are many environmental and organizational issues to address when it comes to performing surgery safely in the midst of a global pandemic. One is whether the virus could be transmitted from one patient to another or to healthcare providers just by being present on a surface that they've come in contact with. And there have been various studies looking at how long coronavirus may survive in different environments. At the bottom of this, from this study in JAMA, they showed that the virus could survive on stainless steel or plastic for up to 7 days. That obviously is a concern in surgical environments where those are very prevalent materials that could be a source of ongoing infection. They haven't associated that directly with spread of infection, but it is at least a concern and something that we should be addressing. There's a recent publication in Anesthesia and Analgesia that outlined ways to sterilize and clean the operating room environment to prevent or minimize the risk of infection spread in that setting. I won't go through all the details, but just to outline, they talk about things like hand hygiene, having alcohol-based rubs available and accessible at the head of the bed where the anesthetist and hands-on providers are working frequently and may be exposing themselves and the environment to spread of the virus. Making sure that the environment is cleaned appropriately. So using at least 70% alcohol solution or 0.5% chlorine solution to wipe down all areas that a patient might come in contact with, or that droplets may spread in the operating room, and having a dedicated team to doing that. Considering patient decolonization, this is not a standard in my environment, but they do recommend considering using things like chlorhexidine mouthwash for affected patients to reduce the viral load prior to manipulating the airway. In addition, they talk about vascular care, which means specifically sterilizing any access to the patient that is connected to a vein. So in this, looking at longer times of disinfecting a hub where medication will be administered prior to giving that medication, and keeping syringes clean and away from dirty environments. Finally, they talk about surveillance, so monitoring closely the increase or change in infections over time to find out where to intervene and how to do that. We'll go step by step of looking at some of the methods to safely perform surgery with a suspected or known COVID patient. And I won't go into all the details, but this figure, which can be found at WFSA, is helpful as a guide to doing this. Before the operation, important steps are making sure that adequate hand hygiene is performed, that there are minimal numbers of personnel in the room during aerosol generating procedures like intubation, that drugs and equipment are prepared ahead of time and don't need to be accessed after the patient has entered the room, and making sure that there's a good plan early. Viral filters are very important to protecting the environment as well as protecting the anesthesia machine. So where these are available, putting them on the expiratory side of the anesthesia circuit or between the mask and an ambu bag that might be used for mask ventilation for a patient can help protect spread of the virus around the environment. During an airway intervention or surgical procedure, communication is critical, making sure that all team members are aware of the airway plan. And then from an anesthesia standpoint, making sure that the method to secure the airway is efficient, so using the most experienced provider to get the airway, doing a rapid sequence induction, avoiding bag mask ventilation if possible, and limiting disconnection of the anesthesia circuit, which would lead to exposure of the room. And finally, after a procedure, thinking about what the patient's destination might be, potentially recovering the patient in the operating room prior to transporting back to their isolation room, or bringing them directly intubated to the ICU. And then always thinking about quality improvement and debriefing as a team for how to do better the next time. Checklists are critically important. I won't go into detail here, but Lifebox and WFSA have this COVID-19 surgical patient checklist, which might be a consideration to use in your environment for treating these patients. And then finally, to close on a couple of thoughts, of course, while we have to plan for that possibility, there are not many patients now that you're probably encountering with a COVID diagnosis that need surgery. At the same time, we need to prepare at a system level to address concerns that patients who may or may not have the disease present to us. There was a publication just last month, actually several on this call may have been involved with this publication, called COVID-19 Preparedness Within the Surgical, Obstetric, and Anesthesia Ecosystem in Sub-Saharan Africa. The authors here outlined 5 key areas to consider as you go forward with doing surgery in your environment in the midst of this pandemic. And I'll go into these. The first area is developing a clear plan for essential operations during the pandemic. I think we'd all agree that continuing with emergency work, cancer surgery with appropriate precautions in place, and shifting toward telephone communication for outpatients are important and sensible things to do. Elective surgery remains an issue of some concern. It does present challenging considerations. Postponing elective surgeries or semi-elective surgeries indefinitely is certainly not a possibility in many settings from a patient health as well as a financial perspective. Thoughtful planning of human and material resources, including bed space and essential services, will be necessary prior to resuming elective surgeries. At my institution, we put those on hold as the pandemic emerged in our setting. And then in May, when we had the ability to test all patients prior to receiving surgery, we reinstituted elective surgeries and have been running at or near our normal volumes since that time. That's not something that's feasible in every setting, but there are some considerations that may be able to be put in place to allow this to happen. The Royal College of Surgeons in the UK has laid out some of these considerations, including considering timing relative to the spread of COVID-19 cases in the environment, the ability and policies for testing staff and patients, the availability of PPE, the availability of other services necessary to do surgery safely, and accommodating for the possibility of staff that need to go into quarantine or isolation, and coordinating all those things in a well-thought plan, addressing all 5 of these issues before putting forward a plan to continue with surgeries. The next area is limiting staff exposure to prevent hospital transmission of the disease. This is a simple algorithm in our setting to use to manage patients who are negative using standard protection, patients who are positive using the measures that we've already talked about, and then this 4th category of patients who are not suspected or positive for the disease, but don't have a negative COVID test or a 0% likelihood of having the condition. For those patients, we still recommend having an anesthesia team only present for intubation and extubation with protective equipment in place, having the rest of the team out of the room and then coming back in to perform the procedure. That is an option and a way to make sure that even patients who may be asymptomatic or pre-symptomatic will not affect the environment or affect healthcare providers with the disease. Conserving PPE and consumables is a critical part of having an adequate plan for doing surgery in the midst of this pandemic, and we've talked about some of the ways to do that. Expanding critical care and repurposing staff to manage an influx of significantly ill patients during this pandemic. This is an important area and one that hopefully will see some progress. I know in a recent teleconference, Dr. Chanda from Zambia talked about their national plan to upskill and upscale intensive care capability in the country. And other countries may be undergoing similar planning at this point. At this time, it does remain a large gap in many parts of the continent and an area for improvement. There are some organizations that have put out some useful information in training non-ICU clinicians in ICU care. And you can see some of these here. I'll put this link towards the end of the presentation as well. Finally, the last point these authors make is to support staff wellness while assisting with difficult ethical consideration. Self-care and wellness must not be neglected, especially given the high demands that we're all facing as we go through this uncertain and challenging environment, and connecting with others, balancing time away from work and time doing energizing activities, and being aware of yourself and your colleagues are all important to making sure that we can sustain our effort as this pandemic progresses. Quickly, I'll finish with a couple of opportunities that have emerged from this that I think are positive. One is we all have something to teach each other. And in this environment, there are actually lessons that have been shared across the globe that have been incredibly useful and demonstrate the importance of collaboration across borders. Technology, like we're using right now, has helped to facilitate this, and hopefully this will be something that endures well beyond the time of this pandemic to enable communication and collaboration across borders. And also science and medicine has been able to provide a high level and high volume of research on this disease, demonstrating our ability as a community to tackle big problems. And hopefully as this pandemic subsides, we'll be able to put that to good use, addressing some of the other big challenges of our age. These are some resources that I've found helpful that we can send along afterwards to access to look for more information. All of these are freely accessible, and another positive opportunity to gain good information related to managing these patients. I'll finish with just this story that I saw yesterday. This is an article out of India about an anesthetist who had COVID-19 and was admitted for oxygen therapy and management to the ICU. He was on high flow nasal cannula oxygen, and another patient in the ICU became critical, started going into respiratory distress. As the ICU team and anesthesia team started their long process of putting on PPE to go intervene for this patient, this anesthetist took off his oxygen, saw that his skills could be put to use, walked over and intubated this patient to save his life. As physicians, and especially as anesthesiologists, we know that when the time comes to act, we step forward and we do the right thing, even when we may be under duress ourselves. This is an honor that we have and a privilege that we have for our patients, and you all exhibit that each and every day. As much as those heroic individual efforts are impressive, ultimately it will be the team-based approach that we're so familiar with as anesthesiologists that will push us to the other side of this challenge. And I do hope that this extends beyond the hospital walls in your environment, where each of you are leaders, to beyond country borders as we seek together to move forward to address these and other challenges. These have been difficult and uncertain times, but we are certainly all in this together. I want to thank all of you for your efforts, as well as for your attention today, and want to shift towards Angela and our panel discussion. Thank you all very much.
Thank you so much, Dr. Kynes. That was a most edifying presentation. You sharing your perspective and experiences has given us a lot to think about, and in many ways made us feel not so alone in the day-to-day navigation of this new normal. So you definitely had my rapt attention, and I see some comments coming in and also into my private chat. I know I've been duly educated on some data I wasn't up to date on, and you've shared some very handy guidelines we can adopt and adapt to our various nuanced contexts. So I'm convinced that as questions keep brewing, that I welcome you all to put them into the chat, and we'll address them later. And now let us welcome our sponsors today. So our sponsors, like I said before, are AbbVie. They are a household name for us. We have Monica Hedder, the medical manager, and Sarona Radley, the key accounts manager for South Africa and Africa region. So I want to note that AbbVie have partnered with KSA and regional societies in various ventures, including simulation training, both in Kijabe Simulation Center and in Nkosi Albert Luthuli Central Hospital, Durban, South Africa. And a total of 50 anesthesiologists and clinical officer anesthetists have been trained to date. So we are very honored and happy to give you the stage now, Monica and Sarona. to tell us more about your products. Welcome.
Good evening, everyone. I'm just quickly going to share my screen with you all. Yeah, please just let me know as soon as you can see it. Because I think there it goes.
Okay.
Yeah.
Can see.
So, yeah, can everyone see my screen?
Yes, we can see. Thank you.
100%, thanks a million. So yes, I'm Monica Heder. I'm the medical manager from AbbVie Pharmaceuticals, and tonight it is my privilege to share with you a short a clinical overview on sevoflurane. So yes, let us not wait any longer. Let's start. So we all know, if we look in terms of sevoflurane, if we look at the pharmacodynamic properties of sevoflurane, we know it's a halogenated anesthetic given by inhalation. It depresses the respiratory function and blood pressure in a dose-related manner. It is also a dose-related cardiac depressant, and it doesn't produce increased or increases in heart rate at doses less than 2 mAc. Then if you look in terms of the pharmacokinetic properties, the low solubility in the blood results in a rapid increase in alveolar concentration upon induction, and then in reverse thereof, it also results in a rapid decrease in alveolar concentration upon cessation. Then the metabolism thereof, the rapid pulmonary elimination actually minimizes the amount of anesthetic then available for metabolism. And then very specifically, if we look at the indications for sevoflurane, we know that it's indicated for both maintenance and induction of general anesthesia, and then also in both adult and pediatric patients. So very interesting is a publication by Delgado Herrera that state a few characteristics of sevoflurane, and I want to share this with you. Yes, so first of all, it has inherent stability. It has low flammability. It is non-pungent, so that's very good for inductions, mask inductions. Then also lack of irritation to the airways. It has a low blood gas solubility. It has minimal cardiovascular and respiratory side effects. It also has minimal end organ effects and minimal effect on cerebral blood flow. There's also a low reactivity with other drugs, and then the vapor pressure and boiling point that enables delivery using a standard vaporization technique. So if we move over to specific cardiovascular and cerebral profile of sevoflurane, we know that sevoflurane has a favorable cardiovascular profile. It is, however, cardioprotective or more cardioprotective compared to some other older volatiles in the market. It also have a decreased risk for arrhythmias. It have a decreased risk for myocardial infarctions, and then therefore it also results in a greater hemodynamic stability of the patient. Then sevoflurane's cerebral hemodynamic profile favors its use in neuroanesthesia. So we know that sevoflurane has a less cerebral vasodilatory effect than some of the older volatiles. It also maintains the ability of cerebral vasculature to respond to changes in perfusion pressure during anesthesia. Then very interesting, Mata et al. Stated that sevoflurane decreases the requirement for pharmacological and mechanical support, and therefore can also decrease the duration of stay in ICU and hospital after surgery. So if we look specifically at the elderly patients that need surgery, a very interesting statement from one of the publications is that all the patients have invasive procedures at nearly 4 times the rate that younger patients have. And we know that the elderly are considered as high-risk patients. due to a high incidence of comorbidities, among many other things. So therefore, maintaining the hemodynamic stability in the elderly during anesthesia is crucial. So post-operative cognitive dysfunction is twice as common in elderly as in younger patients. So therefore, sevoflurane will result in a higher hemodynamic stability compared to some older volatiles. And sevoflurane has a larger molecular size, which aid in preventing post-operative cognitive dysfunction in the elderly. Then if we look at pediatric anesthesia, we know that yearly millions of young children require anesthesia for surgery, some for other procedures and also tests that needs to be done. And we know that the respiratory adverse events are one of the major causes of morbidity and mortalities during pediatric anesthesia. So post-operative nausea and vomiting, as well as emergent delirium, are also factors that we need to consider if we make a choice of our volatile anesthetics that we're going to use. So with sevoflurane, it will result in minimal respiratory side effects due to less irritation to the airways than some of the other older volatiles. It is also has a decreased risk of post-operative nausea and vomiting. And there's no increased incidence of emergent delirium if you compare to some other volatile agents on the market. So in conclusion, if I can say a short statement that was made in Delgado Herrera, they stated that sevoflurane possesses a number of characteristics that approach those of the ideal anesthetic. And yeah, that's just the thought that I want to leave with you guys. And thank you very much for listening and participating and yeah, giving us your time during this a webinar tonight. So I'm going to hand over to my colleague Sarona for a little bit of more on sevoflurane.
Thank you, Monica. I just want to quickly share my screen. Sorry, I'm just battling up a moment. Sorry, I seem to have a little bit of a problem to share. Oh, there we go. I want to put it on slideshow. Thank you, Monica, and thank you once again for having this opportunity to give you a little bit of overview on our value proposition beyond clinical information. I'm Sarona Radley. I'm the Key Accounts Manager for AbbVie, and I've got about 4 slides that I would like to share with you in terms of our value offering. So in terms of currently, if with the current COVID-19 situation worldwide, occupational health and safety is an area of focus for the health workers. And to this point, in the theatre setting, staff exposed to high concentrations of waste anesthetic gases, even for a short period of time, can cause health-related effects, such as headaches. How many times have you heard that theatre staff complain of either fatigue, headaches, or even nausea? And to a more serious health impact, it could lead to difficulty in coordination as well as judgment, liver and kidney disease, and in some cases, there's also a possible risk of impaired fertility. So with regards to safety, occupational safety, and we look at the Altane bottle, the Altane bottle with the quick fill system reduces the risk of leakage as well as spillage when you are filling your vaporizers. No mounting of a separate adapter is required. as it is already to use in a delivery system that does not cause any leakage and minimizes the risk of releasing anesthetic gases into the room air. And should the bottle be dropped by accident, this bottle will not shatter at all. So I also want to just mention that we continue our commitment to provide our facilities with a stable and regular supply of Altane as well as the vaporizers that the facilities require. AbbVie also continues to invest in the healthcare practitioners by means of continued medical education and as well as the investment in the MEPA course in partnership with the Kynes Society of Anesthesia at Kiyabe Simulation Center, which was held in 2019. From a community involvement perspective, we are so proud to participate in the SMILE Foundation, or as it is also known as Operation SMILE. So in conclusion, in summary, Altane has a proven safety and efficacy profile with more than 20 years experience and 1 billion patients exposures to Altane, and is a trusted partner worldwide. And we would like to continue with our partnership. I thank you.
Thank you so much, Monica and Sarona. Thank you for your presentation. Thank you for partnering with us. We are always delighted to share with you and to work with you, and we look forward to continuing to build bridges that promote safe anesthesia. Thank you so much. I think we're time barred. What I'll do is jump right into our next segment and allow me to introduce our panelists for this session. So we have a power team of 5. I'll introduce them in no particular order. From Uganda, we have Dr. Patience Atumanya. She's an anesthesiologist and head of department for anesthesia and critical care at the Uganda Cancer Institute, Kampala, Uganda. Welcome. We also have Dr. Christopher Chanda. He's a consultant pediatric anesthesiologist and national coordinator, anesthesia and critical care with the Ministry of Health, and the head of department of the anesthesia department, University Teaching Hospital in Zambia. Welcome. We have Dr. Edwin Lugazia, consultant cardiothoracic anesthesiologist and head of the anesthesiology department, School of Medicine, and at Muhimbili University of Health and Allied Sciences. This is Tanzania. We have Dr. Prince Murambi. He's a specialist anesthesiologist, Midland State University, the Faculty of Medicine. This is from Zimbabwe. Sorry, just have some mics to mute. And Dr. David Odaba, he's a consultant in anesthesia. My apologies, Shelmis, I think you will have to hunt down. Okay, so we have Dr. David Odaba. He's a consultant in anesthesia and intensive care medicine and a senior instructor at the Aga Khan University Hospital, Nairobi. This is Kenya. Thank you, our panelists, for joining us. For this session, we'll just go around the table, the virtual table, and I ask that our delegates, you can keep posting your questions in the chat. We'll try to get through them. I can see Dr. Kynes trying to work through that as well. And then we'll throw some of those to the entire panel with the main speaker if we have time. We're aiming to end in the next 50 minutes. So Dr. Lugazi, are you online?
Yes, I'm online, though I might be having some noises because you're almost boarding. Yes.
I know, Dr. Lugazia, sorry for our audience. Dr. Lugazia is just about to board a plane on duty to a different station. So he's been so kind as to log on from the airport. So there's some noise behind him. Dr. Lugazia, we just wanted to know if you could tell us a little bit about the level of morale at your hospital. So what are your health providers, what are they most concerned about? What's the level of wellness and professional support that's available for them? We'd like to hear your comments.
Yeah, well, thank you so much. We all know that, well, healthcare providers are backbone of any industry or staff. As you all know, human resource is the most valuable asset. And then as Mark alluded to, we need to have a vibrant and healthy staff to keep the services going. For us, we've gone through different stages of the disease or the pandemic. Initially, when we started, everybody was in panic mode, didn't know what to do, didn't have enough information about the disease. They didn't have enough people to go around, so people had low morale. But with time, as we get enough information on the disease, enough people to go around, they get to know what to do with the patients, and then the morale went up. But we had some high and low swings because of the morbidity and mortality that comes with these patients, the fear of getting involved, the risk of the staff themselves. So it's been up and down. But as for now, we stabilized the morale. We can say that is good. And then as far as their main concern was the risk of getting the disease themselves, knowing the fact that the disease has no cure, definitely. So it's been a tough game, but right now we are okay. And then as far as for support is concerned, I think we've been having some different levels of support at individual level, at facility level. Yeah, one second, yes. Yeah, so we have had some, yes. Yes, so we have had some different support. Yeah, number 5. Yeah. So we have support at different levels, at individual level as well as the facility level. At individual, as Mark said, we had to have people self awareness. Yes. Can you still hear me?
Yes, Dr. Lugazia, we can hear you. I feel like we should let you settle. This is so kind. This is so kind of you to give us a nice running commentary as you move.
Yeah.
If it's okay with you, I'll let you settle down. But thank you. Yes, but thank you so much. Thank you. This forum is just going to give a little snapshot of this, what everyone else is feeling, what we're going through, what our struggles and challenges are, and then put everything into a think tank. And hopefully by the end of this session, we sort of have a snapshot of what the general feel is. Dr. Murambi, are you online? Dr. Murambi, Dr. Murambi is from Zimbabwe. Okay, so, hello? So let me move to Dr. Odaba as we try and get Dr. Murambi on. Dr. Odaba.
Thank you, Angela.
So Odaba is.
Yes, I can hear you, Agnes.
So Dr. Odaba. Dr. Odaba, like I said, is a senior instructor and program director at the Kynes University Hospital, which is a training center for masters in medicine and anesthesiology. So Dr. Odaba, how do you feel the COVID pandemic has affected training in anesthesiology in your setting? And sort of how are you maneuvering this?
Thank you, Angela. Well, it's been a challenge. Good evening, everyone, and welcome to the KSA webinar. As Angela has introduced me, my name's Odaba David. I'm the program director for anesthesia in our university, and it's been quite a challenge to say the least, especially from March. I think right now things are getting a little bit better. Because we have an idea of what we are up against. But our program is, well, both time and competency based. So it's been a challenge in terms of the numbers, especially when the elective numbers went down. So we had to figure out what to do with our residents during that time. And given that they have a limited time of about 4 years within which they're supposed to gain as many competencies as the curriculum expects them to. So that has been a challenge. The first years who are supposed to do the initial assessment of competencies, essentially how to manage an airway, give a basic anesthetic, were adversely affected because, as we all know, when the pandemic started, most of the time we say the most experienced person should manage the airway, which essentially locked out all the junior residents from that experience. So it was essentially a consultant-led service. That was a challenge, and the PPEs were also in short supply initially. At least the supply kind of stabilized later on. And without PPEs and without much experience, so essentially the junior residents were off the rota completely for a couple of months. And that quite impacted on their ability to gain the competencies they needed. Other than that, of course, then there was the directive from the Ministry of Health about social distancing and gatherings, which kind of affected some of our sessions, because some of the courses that we were running, like the basic for ICU, ACLS, ATLS, they couldn't happen. And it's very difficult to run those virtually. So again, there is a period of about 3 months when almost everything came to a halt, and that has impacted quite a significant proportion of the training, especially given that most of our clinical rotations last about 3 months, and the residents are just getting into the next rotation. However, we've had to adapt, as I guess everybody else has had to. And one of the things is that at least the supply of PPEs became regular. And with that, we were able to let our residents back into the theaters safely. We had also to kind of fast track the role of simulation in our training. So we'd have to do a bit of simulation, especially when it comes to airway management, and supplement that with the few cases that were coming along. We had to set up robust psychological support for our residents, some of whom were personally affected by COVID-19, and that has been ongoing, and it's been quite helpful. We had to tinker with our rota a little bit and had to learn how to use the virtual learning environment. So we had to use Moodle and Zoom quite a bit for most of our tutorials, and that is still ongoing. Having said that, despite the challenges, there are also opportunities. I mean, it's a once in a lifetime experience. And I think some of our residents had to have baptism by fire on how to manage team dynamics, how to get around unexpected scenarios, how to plan simulations and move patients from point A to point B, involving the security, the housekeeping staff. So there is that aspect of training that is probably just as important, and I dare say that the current residents are privileged that they have to experience something that probably no one else will experience in the next 100 years. So there's the brighter side of it in terms of experience and learning some non-technical skills that are important in the training of an anesthetist. And there's the flip side where there were quite some challenges with the training based on what we had to adapt to. Thank you.
Wow, Dr. Odaba, that's a nice positive note you're rounding it up with. About that, I can see that you just have a finger on the pulse, and there's no blueprint for this, and we learn as we go. Are you okay as a trainer yourself?
Yes, Angela, I'm okay.
Okay, it's nice. It's good to know. Yes, okay.
Thank you.
Thank you. Dr. Murambi, are you online?
Yes, I can hear you. Yes, I'm online.
Oh, thank you, Dr. Murambi. Welcome. So, Dr. Murambi, I don't know if you'd share in your setting, and this is one of the poll questions. So then now this year, if in your setting, providing elective surgeries, what does the landscape look like on your end? Are you back at pre-pandemic levels? How do you deal with public perceptions of COVID and seeking healthcare? We'd love to hear from you.
Okay, thank you so much for the question. Good evening, the panel and everyone who's taking part in the webinar. I think the straightforward answer to your question, Angela, actually has been answered by Dr. Kynes. In Zimbabwe, I think most African settings can actually agree when the pandemic started early January, we actually saw a lot of it on the news, and we actually had a huge window where we actually didn't have lots of numbers of cases. And fear totally gripped a lot of the public and also the health workers. And in anticipation of that, lockdown and travel restrictions were implemented very early on in our settings. And likewise, during that same time, in terms of health workers going to work and hospitals, everything came to a complete halt. So we stopped doing elective surgery. We only just started doing emergency operations, and also outpatients clinics were shut down. And this was only early March to April, when we had very, very few cases. I would actually attest in our hospital, when we closed these hospitals, we probably only had 5 COVID cases within the province. And then after 2-3 months, we actually then came down to the table and started discussing what was going on and what was happening with all the other patients who had non-COVID conditions, and started entertaining the idea of starting to reopen outpatients clinics and possibly doing emergency elective cases as well. And then unfortunately, that is when the COVID wave started to hit us. So currently now, since the beginning of July, we have had a huge surge in the number of cases, and the cases are actually on a very, very steep rise. And now we are really faced with that dilemma of whether we can actually go on to reopen outpatient clinics, do elective surgeries with the increasing number of cases. At the same time, during the time when we had the closure of hospitals, I must say we probably did not use our PPE very well. So now we are faced with an increased number of COVID cases, and we have shortages of PPE provision for the health workers. And at the same time, we have not been able to provide mandatory testing for all our patients who may need elective surgery. So we have had such a huge problem. And I must say the straightforward answer to that is we are actually not in a position where we can actually provide elective surgery at the moment. Most hospitals within my country are still pretty much operating in emergency mode because we do not have adequate stocks of PPE, and we do not have mandatory testing or enough resources to actually provide testing for people who may need to be taken in for elective surgery. Thank you.
Wow, thank you, Dr. Murambi. No, absolutely, your answer resonates with, I think, with everyone here. I'm impressed by quite the early response. I think you mentioned like 5 cases and elective surgeries were out. So that is quite I can see very proactive policy there. I think I have lots more questions for you, but they might be answered by the next panelist. So I'll move to Dr. Chanda. Thank you, Dr. Murambi. Dr. Chanda, are you online?
Yes.
Thank you, Dr. Chanda. Welcome. Dr. Chanda, as a national coordinator, I think this is a nice perspective, I think, from you. Dr. Chanda represents the Society of Anaesthetists of Zambia. So how would you say that in your setting, anesthesiologists are helping to direct policies on COVID-related matters? So this is hospital level up to the national level. And yeah. Sorry, go ahead. Sorry, I think we're not able to hear you. Sorry, Dr. Chanda.
Hello. Yeah. I'm saying thank you very much for giving us this opportunity to participate.
Sorry. The mic is, the volume is a bit low.
Hello? Can you get me now?
We can hear you a bit. It's faint, but we can hear a bit. I understand you must be in transit as well.
Yes, I'm actually in transit. Yeah.
Thank you for your sacrifice, yes, Dr. Chanda.
Yeah, I was saying actually, thank you very much for this opportunity. I think from the perspective of
Sorry, Doc. I'm not sure if the audience can hear. If one of the co-hosts can confirm if they can hear better. Sorry, Dr. Chanda. I just want to make sure it's not my mic.
Yeah.
It's very faint. We can't hear him.
Dr. Chanda, do you want me to give you a chance to try and troubleshoot? Okay, thank you. feel like I should have gone for a course in reporting. So this is very exciting. Thank you. I mean, all of you, we really appreciate your sacrifices. Honestly, this is spectacular. Dr. Atumanya, are you online? As we wait for Dr. Chanda to try and troubleshoot. Dr. Atumanya.
Yeah.
Wow, I'm trying to decide if your background is real. I'm quite jealous.
I know it's
okay.
Yeah.
Dr. Atumanya represents Uganda, just next to us. So, Dr. Atumanya, for you, do you feel, what are your thoughts about COVID-19 and resource allocation? Do you feel like it's drawing attention and resources away from other pressing areas, or what's your take?
Obviously, the COVID-19 has really drawn so much attention, especially in Uganda. We're among the first countries probably that locked down on case number 1. And a lot of resources have been diverted away from the already resource-constrained healthcare system. And this has left us in a bit of a hiccup. So to just give you a brief background, we had our first case on 1st March, and then we locked down for about 2 months. And at the moment, we have about 1,000 cases, roughly 1,000 cases. And during this lockdown, we had many patients that were stranded in their homes. Some were stranded in hospitals. And for say, our cancer patients, most of them were not receiving their care. And this has actually led us to kind of reappropriate or adapt to a different way of looking at this, because most of our patients, the oncological prognosis was getting worse. If you look at other surgical conditions, and taking in mind that, say, our healthcare system, the health workers are already few, and we're majorly relying on, say, the trainees who are currently at home. Now, that leaves us with a situation where the healthcare system is even worse than it was before. And when you look at the patients that are coming in, already as a country, we have patients that come in at with a late presentation, meaning you have to either work on them, and at the moment with the economical troubles, the transportation issues, we're having more and more delayed surgical presentation. Now, I'll just talk from my point of where we are working. We've had patients, I think we've had one COVID patient who presented with a surgical condition, and a team from Kampala had to travel, because these are the health workers that have been trained in donning and all the PPE, and they had to actually travel to a rural hospital so that they can have the surgery done safely. And when you look at the anesthesia side, a lot of things were not really in order. Say, look at the viral filters, HME filters, changing circuits and all that. These are things that were not commonly used. And now hospitals are putting it as a mandatory requirement before you have, say, operations, have both of them in order, screen patients preoperatively, and ensure that at least they don't have any alert sign, say fevers and whatnot. And for, say, where I work, we've had to let patients have their COVID screens done, at least within the 2 days before they have the operations. We've been lucky because we're near a center that does the COVID testing. And that has made our work easy, because when you look at our OR, it's really not safe for aerosol generating procedures, which will definitely happen if you're dealing with any patient. We've had to reorganize the way we prioritize the patients. For those that could wait, at least we've had to, initially we had a total lockdown and we're only working on emergencies, but we've had to change that and work on patients where we know they must have the operations. And when you look at, say, cancer patients, everyone who's literally coming in, you worry about worsening the prognosis of these patients. And we've had to end up doing we've had to end up working on every patient and opening up to our pre-pandemic numbers. We've also tried to put in measures where patients who present early, at least we get them, say, alternative treatment, say chemotherapy, radiation for those that presented with disease that is in its early onset that can wait before we have surgeries. And then we've also had to look at our PPE in terms of protecting our health workers. We've reduced the number of students or the health workers that are in the OR. We've had to make sure we limit the number of attendants, because in an African setting, we know when a patient goes into hospital, you have about 5 attendants coming in and out, and that will further spread the disease. And this, we think, for all hospitals, if we can try to adapt, we can have a new normal and try to take care of the issues or the surgical issues that were already present pre-pandemic. I think that's all I have to say.
Thank you, Patience. Thank you. Thank you. That's nice and succinct. You sound like you already have a nice, good hold on all the angles. Your response gives us a lot to think about. Yeah. Dr. Chanda, I see you online again.
Yes, yes.
Nice.
Can you get me?
Let's give it a run. Yeah. So we were asking, especially you being the national coordinator, how anesthesiologists have helped to direct, if at all, policy, national, regional, hospital level policy as relates to COVID.
Yes, yes. Are you getting me?
Yes.
Hello? That's better.
It's a bit better, Dr. Chanda.
Oh, yes, yes. Thank you very much. I think from the ministry perspective, we do have an institute that looks at COVID pandemic, and then we act as advisor to that body. But in general, we've really looked at the pandemic from our perspective and the society of anesthetists. I think initially when the pandemic started, really everyone was scared, and we did manage to scale down surgery, more especially elective surgery. But I think over time, I think the pandemic misled us. We thought probably it was dying down. And then the decision to upscale surgery was made. I think just when we did that, that's when the surge started. And what is very unique in our perspective is that there are very few anesthetists who are actually in the city. And there are very few out there, most people in the districts. So the districts are being managed by our colleagues and anesthetists who basically have no access to much of these things. So as ministry and as a society, we started training and upskilling their skills to ensure that they gain the necessary skills to protect themselves and protect patients. And then the other thing that we've done really is to look at oxygen issues. We've gone around the country to look at what are our oxygen capabilities. And currently we are doing some assessments and some procurement of the necessary things we need to ensure that when the surge is there, oxygen is available. And the other thing that we currently do is that we are running the COVID center. And this has really put an extra strain on the anesthetists, because we need to like to come up with a new center within the capital, and that is for the university. So the center that we are running is really run by one hospital, and the number of anesthetists. And this again, mainly we are using residents. And this is clear, and that has been impacted on the training and general how we do things. The other thing that I wanted really to look at is how do we use now other specialties to help in the management of COVID patients. And this for me is quite very critical in our thinking, because anesthetists are here, and most of them are already getting better. So what we've done is that we've come up with a course that we are scaling to non-critical care people. And this mainly includes non-physicians and physicians, surgeries, and we hope to scale it up to surgeries and orthopedic surgeries and substitutes. And we are hopeful that through the ministry, we could convince the other specialties to come on board and help manage this pandemic. Because it's not like a sprint, this will stay on for maybe 1 year, 2 years. And I think in that sense, it means that probably as a body of anesthetists, I don't think we'll be able to manage both the essential surgery and manage the critical care aspect of COVID. So I think in the planning stages, we're thinking that we need to increase the powers that we to ensure that other specialties come on board. So in a nutshell, generally, that's what we're trying to do. And the many other things that have been said basically in terms of oral management, the things that we're trying to scale up in the districts. I think for people in town who are near the city, it's easy for them to have access to PPE, have access to information and all that. I think as ministry, deliberately, we are going out in the district to really upscale the skills for non-physicians who are literally alone for 1 or 2 managing initiatives. I think for me, that is basically the summary of what we're trying to do. Thank you very much.
Thank you, Dr. Chanda. Yeah, I see that with all the baseline constraints are probably magnified during this pandemic, but I think the response, like you're saying, gives us all a lot to think about as well. We commiserate. So we're just going to open this up, and I also allow the panelists and the speaker among themselves to throw questions around the floor if they so will. And I know I see them writing. I think it's generating a good, rich discussion. And also on the chat, we see some questions coming in. I think Dr. Kynes, Dr. Odaba have tried to address some of them. Let me pick up. Some came through a private chat as well. So those ones on my private chat, maybe I'll bring them out into the open, and then we can move on from there. So someone is asking, what is your experience with management of critical COVID-19 patients using NIV from start to recovery or death? I think this is a critical care scenario. Sorry for my terse words. I think this is for you, Dr. Kynes.
Sure, that's an interesting question. I think especially in a setting where mechanical ventilation may not be available, thinking about alternative means to provide oxygen support makes a lot of sense. One caution with non-invasive ventilation or BiPAP, CPAP, is that it can aerosolize secretions and increase the risk of spreading infection to providers present in the room. Using a negative pressure room, making sure that all staff entering have appropriate PPE could minimize those risks. But my understanding is that it is used with caution for that reason. But certainly it could be a life-saving measure. I'll also mention that for patients who get to the point of requiring intubation and mechanical ventilation with COVID, the disease can be quite severe, and they usually require significant support for, hard to say, at least 3 days and sometimes much longer. And that may not be a patient that's appropriate to be managed with non-invasive ventilation, and they may need to find some means of providing mechanical ventilation. So that should be a consideration for a patient that's in that clinical situation as well.
Thank you, Dr. Kynes. I'm not sure for the panelists. Okay, our panel is from the States, East Africa, Southern Africa. Are negative pressure rooms, is that a reality for all of us, maybe the 5 panelists? Negative pressure operation theaters, ETC, or isolation rooms in critical care settings?
No, it's not really been a reality
So,
for us.
Doctor, you see, patients, you say no.
Yeah. We've had to think of,
in Zimbabwe,
Sorry, go ahead, Dr. Murambi.
In Zimbabwe, we're currently having 2 main COVID ICU centers that are being refurbished, and they are actually installing negative pressure ventilation systems.
Okay.
So I think in a little by a week or 2, we should have those facilities available.
Okay, okay. About how many do you think? It's going to be in one facility, a central facility?
Yes, we've got 2. I work in the third largest town in Zimbabwe, but in the capital city, they have another COVID ICU that has got negative pressure ventilation. So we have 2 centers. Yeah, so we have 2 centers.
Okay. Dr. Atumanya, sorry, we cut you off.
Sorry, that's fine. So I think previously that's something that hadn't yet been thought of, but in one of the ICUs, that's in Mulago Hospital, which is the major COVID ICU, at least they're trying to activate the negative pressure rooms. However, in the ORs, most of us were using air cons, which is really more detrimental than it is helpful. And we've had to think of trying to get alternatives like the HEPA filters, which can be standalone without having to undo the entire ventilation system. And those are underway into procurement, and we see how that goes.
Okay. Dr. Odaba?
Well, I think it's a mixed picture from our setup, in the sense that we do have quite a number of negative pressure rooms in the ICU and in the HDU. And in the event that those are the priority rooms for COVID patients. So when they come in and there is a negative pressure room that is free, then that's the place where we'd admit them. But then, of course, the numbers keep fluctuating. So occasionally we have to admit patients in non-negative pressure rooms and ventilate them in those rooms. Just to add on to what Matt was saying, so, for some reason we've had a few good outcomes with NIV. Of course, we put the patients in the negative pressure rooms, but these are patients who are not really with critical care COVID. They are not. They probably have severe COVID-19, so they require quite high amounts of oxygen, and they're on non-rebreather masks at 10, 15 liters. And we found some of them that when we put them on NIV, we actually avoid intubation and they turn around in a day or 2. But of course, if we give you a trial of NIV and the oxygenation is not getting any better, then we quickly move on to intubation. So we've had a few who we've had to stop at NIV because their oxygenation actually got better, and we avoided intubating them. But then there are those who don't respond to NIV at all, and we swiftly move on to intubation. The theaters, unfortunately, don't have negative pressure. In fact, they have positive pressure for infection control. So we know that when we get to the OR, negative pressure will not be an option. But what we've done is we have dedicated theaters for COVID patients, confirmed or suspected, because we are doing pre-op COVID tests at least 48 hours before the elective surgeries. So for patients who are coming in for elective surgery, they all undergo a mandatory COVID test. It's free of charge, so the patient doesn't pay for them. And what happens that if the test is positive, then the surgery is postponed to a later date. If the test is negative, then we go ahead with the surgery. If it's an emergency surgery or the patient is confirmed positive, then we send them to a dedicated COVID theater where we assume they are positive, even if we don't have the results, and we just don full PPEs for the entire team.
Thank you. So clearly, as guidelines are guidelines, and we adopt them and adapt them to our personal context, right? So let's just go back to the chat. If again, the panelists, since you are the ones who are allowed to have your mics on, you're free to bombard each other on stage. There's a question here about succinylcholine. Yes, so I think they want to know, Matt and the rest of the panel, what your take on is with succinylcholine as a muscle relaxant for RSI, given that it's cheap and readily available in our setting. So we want to hear what us in East and Southern Africa and then up there in Texas. Is it a go-to drug or one of those things where your residents are like, what is succinylcholine?
Yeah, that's interesting. You know, that has changed even since I finished training 5 years ago with the emergence of Sugamidex, which is common in our setting. But the ability to reverse rocuronium immediately if necessary. So many residents have opted to use only rocuronium and may train exclusively with that. That being said, Sugamidex is not perfect and it's not widely available. So for a true rapid sequence intubation, especially with a patient who may have an uncertain airway, I still use succinylcholine as an option. So it hasn't fallen completely out of favor. Even among my pediatric patients, where there are some additional concerns about undiagnosed muscle disorders, I still do use it, and I feel safe doing that as long as the potassium, is suspected to be within normal limits and there aren't other contraindications from a neuromuscular or burn standpoint that might put them at risk. So yeah, it still is used, and the important point for patients being managed who are suspected of having COVID is that there should be as little airway manipulation as possible. So mask ventilation, any positive pressure ventilation where the trachea is not sealed with a cuffed endotracheal tube has the potential to spread aerosols into the room and with providers. So recommendations have been to pre-oxygenate with an adequate seal, use a two-handed mask if necessary to provide positive pressure ventilation, and then do a rapid sequence induction, minimizing the time from induction to intubation and fully securing the airway.
Thank you. Thanks. Thank you. This one, okay, I'll send this to everybody. For critical care, there's a lot of critical care questions, yeah? So Dr. Odaba and also the entire panel, people just want a snapshot of the outcomes you're having in critical care spaces, outcome in those patients you ventilate, are they extubating to discharge? I don't know if any of you have comments. Dr. Odaba, you could go first, and then.
Sorry about that, some technological challenges. So I think for the critical COVID patients, we've had mixed results, and that's simply because it's been dependent on many other factors, whether this patient has comorbidities, their age, and the degree of hypoxemia they've come in with. I would say we're probably doing on roughly a mortality of about 30%. So up to 70% of intubated and mechanically ventilated patients are actually getting off the ventilator. What some of the things that we've noticed is that some of them require quite a bit of time before we can actually wean them off the ventilator, so much so that they even turn negative. Their subsequent COVID tests turn negative, but their respiratory system hasn't recovered yet. And I guess that is just from the severity of lung damage, the degree of lung damage that comes with the inflammation and the scarring that results. So you end up with patients who have recovered from their COVID-19, but their lungs are so damaged that they've become so difficult to get off the ventilator. So we still have a few of those who have become long-term stayers in our ICU just because we are finding it's difficult to get them off the ventilator. But the vast majority of patients, within a week or so, they would get better, and usually within 3 or 4 days, we know which direction they are going, because there are some who turn around pretty quickly and start getting better, and you start weaning them off the ventilation and turning down the FiO2. A few of them would require very high level support for a week or two. I think by then, most of them, you would have a rough idea of which direction they are taking. So we have, at the moment, I think we have a couple of patients who have been with us for a while. They've turned negative, but they still require mechanical ventilation. But generally speaking, the vast majority of them, we are able to successfully wean them off the ventilators.
I don't know if, thank you. That's a succinct answer. Matt, does it sound familiar, similar, sort of in the setting you are in?
Yeah, I'd say it's similar, and I don't work in the critical care units, but from reports that I've seen, it has been interesting that our performance has improved over time. There are some things that we're learning, and Dr. Odaba probably has had the same experience about how patients progress through the illness. Things like the need for aggressive anticoagulation and the high risk of thromboembolism in these patients. Other things like using prone mechanical ventilation or even prone ventilation with supplemental oxygen therapy as a way to improve oxygenation. Those things, as well as basic fundamental critical care, have improved the outcomes over time for COVID patients that we've seen, and it's been true in other settings as well.
Hello, Angela.
Hello?
Yes. Maybe I can make a comment on just our experiences here.
Absolutely.
I think a bit different actually, because here I think our mortality would be more than 50% in general. I think there's differences in the way the continuum of care is, because most of our patients, we are getting them really pretty bad, because we have one center, and therefore they have to be channeled into that center. I think the treatment prior to admission to ICU is one of the issues that really impact on outcomes, because many patients are really coming in really toxic. So moving forward.
You're fading a bit, but I think we're getting that they're coming pretty late in the disease course.
Yeah, exactly, yes. So we feel that the pre-treatment before ICU is very, very critical, and how you drive the treatment very, very early. I think that would be very, very critical. I think that's the landscape that we can do.
Okay. Thank you. Again, those contextual nuances which are so important. Thank you. Wow, I see our clock running. But the comments are thick and fast in a positive way. Dr. Kynes' presentation is so well received. And for the panelists, your comments and your contributions are resonating well with the audience. I think people are inspired and feel like we're in this together as we share knowledge. Unfortunately, because of our time, we're going to have to begin wrapping up. I don't know if the panelists have any closing statements, if Dr. Kynes has any closing remarks.
I do, yes. Thank you, Angela, and thank you to all of you who joined this call, to the panelists and to all the people that are listening in and contributing to the chat. Obviously, to me, this emphasizes how important this issue is, how much more room and opportunity there is for collaboration and exchange of information. And hopefully, this is one of the lasting effects in a good way of this pandemic, that the opportunities to do this around COVID and other issues related to anesthesia and patient care will continue on into the future. So great honor to be with you all today. Thank you very much for having me.
Thank you, Dr. Kynes. Any of our panelists? I'm sure, I know Dr. Odaba well, he doesn't say goodbye very well. Dr. Chanda, thank you for logging in from your station. Dr. Lugazia must be airborne. Dr. Atumanya, Dr. Murambi,
Thank you so much. Thank you so much for affording me the chance to be part of the panel and for all the wise words that we got from Dr. Kynes. Thank you so much.
Thank you for joining us and partnering with us. We don't take it for granted. Dr. Tumanya, thank you as well.
Welcome. Thank you for having me.
Thank you. Dr. Odaba.
Thank you, Angela.
Okay, so for everyone, it's clearly unanimous that this was a most informative, interactive, relevant, and well orchestrated and a wholesome discussion. We thank you, everybody, for your contributions. We thank you, our sponsors, AbbVie, for working with us, not just in this event, but in our regular clinical spaces. And you, our esteemed delegates, thank you for joining us. It's not lost on us what a big honor it is to have you join us and learn with us and contribute to this space. To the KSA Executive Committee, we thank you for organizing and running the CME calendar for KSA members and the other society members from across the globe for fronting pertinent discussions and supporting this forum. To Ms. Shelmith Macharia, thank you for being so faithful, for being so particular and running a wonderful show. Remember, we are uploading even this recording, so you can find these on the website, even if you just Google Anesthesia Kenya. And also on YouTube, you'll find these recordings of these videos. It's free to log in and listen. We welcome and invite you to share your preferences and suggestions as regards the subject matter that we tackle, and your comments, criticisms, and contributions are exactly what make this a rewarding interaction. And so with that, we will wholeheartedly invite you to next week's webinar, same time, same place. Good night, everybody.